Hi, my name is Katie Booth, and today I'm going to be talking to you about ABO hemolytic disease of the fetus and newborn. First, let's talk a little bit about what it is. So, hemolytic disease of the fetus and newborn is when the mom produces an IgG antibody that crosses through the placenta and attaches to the fetuses or neonates, specifically red blood cells, antigens, and can cause destruction. In this case, for the ABO hemolytic disease, it is caused by an ABO incompatibility between mom and baby. Usually the moms are type O in this situation, but they can also be type A, type B. Anytime there's an incompatibility, we can have this ABO hemolytic disease. Type O moms typically produce anti-A and anti-B in the IgM form, but they can also make anti-A and anti-B in an IgG form. This IgG form is in a lower titer, but still exists. But type O also makes an anti-AB in the form of IgG, and that can also cross the placenta and cause an incompatibility. This transfer starts around 12 weeks gestation and will continue throughout the entire pregnancy. And unlike the Rh form of this disease, the ABO form can affect the first pregnancy because these are what's considered a natural antibody, so we produce them our entire lives. And this is the most common cause of the hemolytic disease of the fetus and newborn. Let's talk about the difference between the hemolytic disease of the fetus versus the hemolytic disease of the newborn. So in the hemolytic disease of the fetus, this is before the baby's born. The mom is exposed to the antigens from the fetus. Now in the ABO form, the mom already produces the antibodies naturally, but in other forms of this disease, that antigen needs to stimulate the IgG antibodies. So the ABO ones already exist in this case. But then those IgG antibodies will cross the placenta, and the mom's antibodies will bind to the fetus's red cells at the matching antigen site. And then this is where the red cell destruction begins. So once the fetal red cells are being destroyed, fetal hemoglobin is released. And from that release, the hemoglobin breaks down into what we call indirect bilirubin. And in the case of the fetus, the bilirubin gets sent back through the placenta and is cleared out by mom. So it's not often noticed in the ABO incompatibility. It's usually very mild and subclinical. But if anything severe does occur, we can see anemia in the fetus. Fetal liver and spleens may be enlarged due to an increased RBC production because the red cells are being destroyed, so it's trying to overproduce. And in extreme cases, we can see cardiac failure and something called hydrops fetalis, which is just edema in the peritoneal and pleural cavities. So this can cause a lot of havoc for the baby, but luckily in the ABO incompatibility, it's usually not an issue. But now to talk about when the baby is born. So the hemolytic disease of the newborn, whole first part of the process is the same. The mother's exposed while she's pregnant to the antigens, produces the antibodies, or in the ABO sense, she naturally produces them. They cross the placenta, start destroying red cells. Mom is currently clearing out the bilirubin that is being produced or is a byproduct of the red cell breakdown. But then the baby is born, often premature in these cases, but then the red cell destruction continues after birth, but they are now no longer connected to mom, so mom cannot do the heavy lifting. So as the indirect bilirubin continues to increase, babies can't, specifically newborns, can't conjugate this bilirubin. And they lack something called glucuronosol transferase, which helps with the conjugation of bilirubin. And since they lack this, they're unable to do that. So with nowhere for the indirect bilirubin to go, it starts binding with albumin. Now, although there is a large amount of albumin eventually we hit capacity, and then we continue to exceed that, and that's when the indirect bilirubin starts to look for other binding sites. And it'll start to bind to the tissues. And that's where we begin as providers to be able to see physical characteristics of this disease. Jaundice will occur, which is where we're seeing yellowing of the skin, yellowing of the eyes, the hands, the feet. You'll start to see changes in the baby's appearance. And that unconjugated bilirubin, or indirect bilirubin, continues to, if it continues to build, it can cross over the blood-brain barrier and bind to the central nervous system tissues. And this is extremely dangerous because it can result in permanent brain damage, deafness, mental retardation, or even death. So it's very important that we see these conditions and get them treated as soon as we can. So what do we see in the lab? We may not necessarily see the patient, but in the lab, we're going to see a few things on paper. We're going to see that, one, mother's blood type is incompatible with baby's blood type. So typically after the baby is born, a cord blood sample is sent to the lab and is tested for the baby's blood type. And then we compare mom to baby and we find out if there's an incompatibility. Now, in my experience as a lab tech, I have found that every facility has different procedures. The one I currently work at only tests type O moms because those are the most common blood type for the mother to produce this incompatibility. So any mom that is A or B positive doesn't get the cord blood tested. So some may slip through the cracks. But once we find that incompatibility, we'll do a DAT on the baby. And for us, we'll see a positive DAT in the case of a hemolytic disease of the newborn. So once we see that, we kind of are indicated of what's going on. It can also cause a mild anemia. Your nucleated red and retic counts might be mildly increased because with that red cell destruction, the baby's going to continue to try to produce more red cells. We might see some spherocytes. And obviously in the chemistry sense, we're going to see the bilirubin mildly increasing. But it does typically peak around 24 to 48 hours after birth because the titers of mom's antibodies are slowing down. They're no longer being exposed to the antibodies, so eventually all the antibodies will bind and it can only peak to so high. So once we've diagnosed with laboratory findings, it's time to treat. So treatment of this for the hemolytic disease of the newborn, especially in the milder cases of the ABO form of it, super simple. Basic sunlight exposure for your baby. Sunlight breaks down bilirubin. That's why we protect our samples in the lab from light if we're testing the bilirubin, because light breaks down bilirubin, even through the skin. But more commonly, babies will go into something called a bilibed, and it's just a phototherapy where usually you'll see like sunglasses put on the baby, and or like sun stickers that look like sunglasses to protect their eyes from the UV lights, and they'll get put in a bed that emits light onto the baby's skin to break down that bilirubin. So now that we've talked about all of the clinical findings and what exactly it is, let's review a patient. Starting with our patient information, we have a male neonate baby, about 5.5 pounds, which is indicating he was a little premature, and he is exclusively breastfeeding with mom, so no formula. On day 1, we're seeing some jaundice, so some yellowing of the skin, maybe a little yellowing of the hands and feet. But so we're seeing that, and as we go, day 2, day 3, day 4, we test the bilirubin, so now we're getting pretty far along in the sense of this disease, and we see a bilirubin of 13.4 milligrams per deciliter. Now, to look at some of the ranges, anything greater than 5, we're going to consider hyperbilirubinemia, which is bilirubin in the blood. So above 5, we're seeing an increased amount. If it's between 5 and 15, it's considered mild, but if it's greater than 15, we're going to consider it critical. So on day 5, so the next day, the bilirubin is tested, and we are now at a 17.2 milligrams per deciliter. This is now in the critical range. So the baby is just increasing in the bilirubin. So they took that total and they did an indirect, because we want to know what percent of this bilirubin is not being conjugated. So the indirect was a 16.1. So most of this baby's bilirubin is not being conjugated. It's not doing what it's supposed to do. So we're seeing an abundance of this extra indirect bilirubin, which is why we're seeing the jaundice. We're seeing spherocytes of 2+, which can be an indicator. Hemoglobin of 17.7, so it doesn't look like it's causing any anemia at this time. A corrected retic count of 3.2%, so it looks like we are compensating a little bit. And thyroid studies were normal. So looking at these lab results, the next step was the physician ordered the mom and the baby's blood to be sent to the blood bank for further testing. Blood bank findings. The baby typed as an A positive and the mother typed as a B positive. So we do have an ABO incompatibility between mom and baby in this sense. So the DAT was performed, and at the IgG form of the DAT, we had a 2+ positive, indicating that we had antigens, like an antigen and an antibody connection. So there were antibodies that were connected to these red cells. We did a heat elution at 56 degrees Celsius with intermittent agitation using 6% bovine serum albumin for 10 minutes. Long story short, we did an elution to break those antibodies off so we could test and see what is specifically causing these issues. So we tested that eluate, and we tested it against an A1 cells, B cells, and O pooled cells. This would give us the idea of, are we looking at ABO, or are we looking at another form of the hemolytic disease? But this did demonstrate an anti-A, confirming that this was an ABO incompatibility. We then tested the eluate also in an antibody screen to just make sure we don't have another type of antibody, like an allo antibody or an Rh antibody, which wouldn't have made sense with the mother's blood type. But after that testing, it came out negative. So this is a clear indication that we are only looking at an ABO incompatibility in this case. So then they did a titer on the mother's serum, and they found that she had a high titer of IgG anti-A in her system. So that high titer is what is causing this hemolytic disease and causing so many issues for this baby. So now we've confirmed that this is an ABO incompatibility, and this is, now we just have to treat the baby for it. So this baby was then treated under intense light emitting diode, or LED, phototherapy, so a Billy bed, for 3 days straight in increments. They did times for the baby to be in, not in 3 days, like 72 hours straight. And after those 3 days, the patient was then discharged with stable vitals and told to follow up later. So about 7 days, we did the follow-up, and the total serum bilirubin was a 2.8 milligrams per deciliter, showing that the phototherapy worked, and the baby is now thriving from this disease, and we have a happy ending here. We have a happy, healthy baby boy. So to round everything out, I just want to say that most cases of ABO, hemolytic disease of the newborn, they're mild. They don't usually carry super amounts of severity, but it can vary at how severe that it can be. So it should not be underestimated. And although it's commonly associated with type O moms, which, like my facility, we only test the O moms, it should not be overlooked for other blood types, because it absolutely can occur on a broader spectrum with other blood types. And in this case, the neonate was very lucky to respond well to the treatment and was discharged in good health, and that's just showing how important it is for us to make these diagnoses in a very timely manner and manage the treatment as soon as we can, and we will see less permanent damage in these cases. And that was everything. Thank you for listening to my presentation.